My name is M.MARCHETTI. I'll be speaking about pigmentation of the soul. In this podcast, we'll review the appearance of nevi, melanoma, and some other acral pigmentations of the soles. It's important to understand that the anatomy of these sites is distinct. We have the dermatoglyphics on the volar surfaces characterized by ridges and furrows. There are three major patterns of benign acral nevi: parallel furrow, lattice, and fibrillar patterns. The parallel furrow pattern is characterized by linear pigmentation of the furrow, and it spares the ridges. In this example, you can see linear brown pigmentation of the furrow. The furrow is characteristically thinner than the ridge. There are some variants of the parallel furrow pattern. We just saw the single line variant. In addition, there's the single dotted line variant, the double line variant, where you have two parallel lines that outline the furrow, and the double dotted line variant. The second pattern is the lattice-like pattern. It's a variant of the parallel furrow pattern. In addition to the linear pigmentation of the furrows, you have crossing parallel lines that go across the ridges, and you could conceptualize them as tunnels that connect the furrows. This is an example. You see linear brown pigmentation of the furrows and crisscrossing parallel lines that cross the ridges. The third pattern is the fibrillar pattern. It's characterized by dense fibrillar pigmentation of these multiple thin parallel lines. There's no respect for the ridges and the furrows. Here's an example of a lightly pigmented, a tan fibrillar pattern. These patterns have some anatomic distribution. The fibrillar pattern is most frequently seen on weight-bearing sites, the furrow pattern on weight-bearing edges, and the lattice pattern on the arches. A neat trick that can be helpful when evaluating lesions with a fibrillar pattern is to use oblique or tangential dermoscopy. Applying that tangential pressure can change the appearance of a regular fibrillar pattern into a parallel furrow pattern. Less common acral nevus patterns: the globular pattern, which is seen in congenital lesions; homogeneous, so a brown structureless lesion, one color, small in size; finally, the reticular pattern, most commonly seen on the arch. Another minor dermoscopic pattern is seen in acral congenital nevi. You have brown globules or clods that are situated on the ridges, and sometimes, in addition, you see parallel pigmentation of the furrows, and that's called the peas in pod variant. What about melanoma patterns? I consider two primary patterns. The first is the parallel ridge, and the second is a chaotic or disorganized appearance in either color or structure. The parallel ridge pattern, you have pigmentation of the ridge, it spares the furrow. This is particularly helpful when evaluating early presentations of acral lentiginous melanoma or evaluating the edges of a lesion, and you'll often see this pattern at that location. Here's an example of a large plaque. We're looking at a little pigmented area along the periphery, and there you can see brown pigmentation that encompasses the ridges and spares the furrows. A beautiful example published in the British Journal in 2015, beautiful example of pigmentation along the ridges, which you can clearly identify because the eccrine pores open up on the ridges. Nice example. The second presentation is the chaotic pigmentation, color, and its synonyms. Different terms that have been used to describe this: irregular diffuse pigmentation of variable brown shades, a bizarre multi-component pattern, asymmetry of colors, atypical blotch. The bottom line is that all of these lesions you can see on this slide have multiple colors and structures. Here's an example of a structureless patch on the sole characterized by multiple colors. It's chaotic, it's disorganized, it's a multi-component pattern. This example, you see globules, you see network, blue-white veil, multi-component pattern of melanoma. A minor pattern of melanoma is the atypical fibrillar pattern. This is less frequently seen. Instead of seeing the parallel bands of uniform width in one color, we see multiple colors, variation in the width of the lines, as well as their length. Don't forget that non-acral melanoma-specific structures can be seen in acral lentiginous melanoma and more frequently in invasive presentations. Here's an example of an amelanotic volar presentation of melanoma, and you see dotted vessels that are distributed chaotically along the ridges. A nice approach for these lesions, particularly for novices, is the revised three-step algorithm published by Koga in 2011. The first question when evaluating an acquired melanocytic lesion on acrovolar skin: is there a parallel ridge pattern present? If so, biopsy the lesion. If not, you look, does the entire lesion have a benign typical pattern, furrow, lattice, or fibrillar? If yes, you can reassure the patient and send them home. If the lesion doesn't manifest a benign pattern, you measure it. If it's less than or equal to 7 millimeters, monitor. If it's greater than 7 millimeters, biopsy, especially if they're older individuals. What are some other pigmentations of the sole? Subcorneal hemorrhage, very common in those with trauma to the feet. Maybe they're athletes, maybe they're wearing shoes that don't fit them anymore. Typically you see a very dark reddish black color. Sometimes cracks can occur in the stratum corneum. You can often scrape this away and confirm the diagnosis. More subtle presentations, like in this individual, you see pigmentation actually along the ridges, but you see those reddish blackish globules or clods on the ridge. Those have been termed pebbles on the ridges. They occur because the blood traverses around the eccrine coils and gets trapped between the stratum corneum and the epidermis. Lastly, Tinian Nigra. This is a superficial fungal infection of the stratum corneum, occurs on acral sites. It can mimic the appearance of melanoma. Here's an example of a large patch. Dermoscopically, it's quite characteristic with these spicule-like or hyphal-like pigmented structures that don't obey the ridges or the furrows. So, applying what you've learned in this podcast, which of these two lesions is melanoma? On clinical grounds, may be quite difficult. Dermoscopically, however, it's very easy. The lesion on the right, parallel ridge pattern, melanoma. The lesion on the left has a furrow, parallel pattern, and that's a nevus. Thank you for your attention.